Thank you for inviting me to speak today. It's always a pleasure to share our experiences with both the patients and the physicians, and really what ASAP has made a unique doctor-patient collaborative effort, which benefits both sides of this equation. The topic of my conversation today is about what makes the Chiari headache so unique. Headache in Chiari is one of the really more salient symptoms. And it's oftentimes the presenting symptom that frequently gets pushed to the side because it's a chronic experience of headache that oftentimes is misleading in its longevity and chronicity. So we'd like to take a look at how the Chiari patient characterizes their unique experience with headache, and what are clues in the headache presentation that may help us better diagnose Chiari malformation, teach neurologists to be aware and astute about certain elements of this. Also, to take a look at any sort of clinical assessments that may affect the patient's experience and can amount to some bedside techniques that may help clinicians understand what the headache is about. And what are the nuances of the headache presentation that can help us identify the most appropriate treatment strategies? We've heard and do hear a lot about the surgical approaches, but there are some medical approaches to the management of chronic headache. So the traditional neurology dogma established in the late 1800s by Chiari and following people interested in this, including Arnold and a whole host of people that extended into the 1950s, described Chiari malformation basically as an occipital cough headache. So the exacerbation of the headache by cough became early identified as a unique part of this. Of course, patients identified by Chiari were really explored an autopsy series, so they were very severely affected patients. And the initial presentation was occipital cough headache, ataxia, and downbeat nystagmus. So the pressure in the brainstem not only affecting cognitive and sensory motor function, but also ocular motor and coordinative aspects of this. And many of the patients can presented with also syringomyelia, which occurs about maybe 10 or 15 or more % of patients with Chiari. If you look at syringomyelia by itself, probably Chiari is the most common cause. Maybe 70% of syrinx patients have to be explored for the presence of a possible Chiari malformation. It's important not to miss that. In the late 1980s, we began to see the identification of imaging studies that allowed us to have some criteria of tonsillar descent, which became a kind of a hallmark for the investigation of patients. Chiari malformation was redefined by a landmark paper in 1999 by Dr. Miller and a group at the Chiari Institute. And clearly, suboccipital headache with frequent retroorbital component was clearly identified as the most salient symptom in about 81% of the patients. But clearly the important presenting aspect of this was that there were a host of associated problems: ocular disturbances, vestibular imbalance complaints, dysesthesias, numbness and tingling, primarily in the upper extremities. We've heard about chronic fatigue, and we've heard about impaired memory and concentration. All of these were frequently associated. So the idea of looking at the patient experience, that was early, the patients describe it as an early headache developing in the teens and early 20s. In children, it's often affecting behavior. Oftentimes, kids will have head banging maneuvers, not knowing what to do with themselves and where this pain in their head is coming from. There's oftentimes sullen and non-participatory behavior, probably associated with chronic pain. There also may be rare episodes of vomiting, oftentimes mistaken early on for gastrointestinal problems, and many patients are worked up by gastroenterologists before it's realized that there's really a central nervous system problem going on. Not infrequently, patients will also describe, as they get older and are more verbal about things, that they've always suffered with headache. this is quite different from the most common headache symptom of migraine, which is clearly an episodic kind of headache. The Chiari headache tends to be one of a chronic burden of daily involvement aggravated by exertion and positional changes. There's also in the female part of the issue, which is more common in Chiari, association with menstrual period and PMS symptoms when there is some associated increase in intracranial pressure. So as we go forward in the discussion today, we'll see that chronically raised intracranial pressure is an important aspect of this. Early on, cine flow studies showed, as you can see in this dynamic picture here, the choke point at the cranial-cervical junction, where tonsillar descent interferes with the free flow of spinal fluid from the cranial compartment into the spinal compartment, which sort of acts as a capacitive reservoir to take up the pressure changes that are distributed through the head. As Dr. Grant talked about these cognitive changes, some of this bottled up pressure in the head is probably underlying a lot of these widespread changes and far-reaching symptomatic complaints that patients have. So although the choke point is at the cranial-cervical junction, we have a systemic cranial problem related probably to raised intracranial pressure. This is an interesting MRI technique which kind of amplifies the movement that normally takes place with the cardiac activity. You can see the pulsatile changes here, which are more dramatic here, but it's amplified by a particular MRI technique where you can see the pulsatile movement of the brain stem. And you can envision in a Chiari malformation where this is constricted to a significant degree, that the pounding impact on the brain stem and the cerebral tonsils, that this is producing symptomatic involvement. As time went on in understanding the dynamics of CSF formation and CSF production and how intracranial pressure relates to all of this, we began to understand that the CSF production remains at a very steady pace of about 0.33 millimeters per minute. We make about 3 times the capacity of the intracranial space each day with spinal fluid. So the intracranial space for spinal fluid is about 150 cc's. And we make about a liter or about 450 cc's of spinal fluid a day. So what happens with all that fluid? Well, it's absorbed through absorptive channels at the top of the head and through absorptive channels less dramatically along the spinal canal. So this is also, the formation is not affected much by health and disease. It just continues along at this pace, irrespective of what the pressure in the system is. The absorption, however, is driven by the pressure. So as pressure increases, absorption increases, and you get a point at which this stabilizes at the general normative kind of intracranial pressure of 100 to 150 or 180 millimeters of water. And that's where a patient kind of sits. And if absorption is affected, this line moves further out and intracranial pressure gradually increases with decrease in absorptive capacity. So what's happening in a Chiari patient? We're not exactly sure, but the more we explore CSF studies, the more we begin to see that intracranial pressure is chronically increased in many of these patients. Postoperatively, when CSF pressure is looked at, several neurosurgeons, including our experience, has been that patients usually gravitate between an intracranial pressure of 220 to 260 or so, which is clearly elevated, but not elevated enough to qualify them for shunting, thank goodness, because CSF shunts are a labor-intensive process and very difficult to maintain long-term, as experienced by patients with other types of hydrocephalus that have multiple shunt revisions through their lifetime. It becomes an increasingly terrible problem. So we don't want to see patients with Chiari being shunted if we can at all prevent that. We know from the neurosurgical experience that posterior fossa decompression significantly relieves this occipital headache complaint. It's the most striking appearance that you see in the post-op patient, despite the fact that they have a deep surgical scar in the occipital area, that they will experience a reduction in their headache almost immediately post-operatively. I had an experience with a 10-year-old young boy who was very sullen, somewhat overweight, non-participatory. And the day after surgery on rounds, we said, well, how are you feeling today? And his mother said, well, he's in the children's playroom. And he was actively interacting with a smile on his face. And I said, how are you feeling today? He said, my headache's gone. And before, he actually couldn't describe that he had a headache. I'm not sure if he knew exactly what a headache was. But when he got relief from the surgical experience, it was clear to him that he was much improved. So we know that the surgical treatment certainly relieves this salient occipital headache symptom. But there tends to be recurrence of headaches, sometimes at 3 to 6 months post-op. And this is where neurologists frequently see some of these patients. And the more we explore them, the more we see that there are problems with intracranial pressure. Neurosurgeons have come a long way from the trephination treatments for headache, which date to prehistoric time. But we see now that when neurosurgeons expose this area, looking posteriorly at the tonsils, that there is compression of the tonsils, there's deformation of the brainstem, sometimes called a medullary bump here, because of the compression of the tonsils at the constriction at the craniocervical junction. There is thickening of the dural membranes, there are adhesions of the tonsils, and at times it's difficult to tease this out because underlying here are the vertebral arteries and the other lower brainstem cranial nerve processes, which are difficult to explore, and frequently leads many neurosurgeons not to want to venture into doing more than a bone-only decompression. This is difficult territory, but in most of the patients that have had recurrence of problems from bone-only decompressions, we know that about 25% of those patients come back for reoperative surgery with shrinking of the cerebellar tonsils, which is a much more complicated surgical procedure and much more hazardous. In 2009, the experience at the Chiari Institute, we tended to stratify patients. What sort of problems were we seeing coming through as potential Chiari patients? Well, classical Chiari, which was basically a small posterior fossa by morphometric measurements, was about 50% of those patients. But we became increasingly interested in patients that had connective tissue disease and craniocervical instability, which accounted for about almost a third of the patients we began to see, and a lesser number of patients with tethered cord problems. So we began to expand our experience with this and look back to our patient evaluation to see if we can help refine our understanding of what's going on. So clinical assessments can be helpful. What is the response to jugular compression, for instance? Patients with headache, if you apply some jugular compression, patients with raised intracranial pressure will oftentimes experience the sudden increase in their headache, which is something that they see with activities. They tend to be couch potatoes because running, jumping, doing exercise aggravates the headache. It's because all of these activities increase intracranial pressure, and that's where the rubber meets the road in the posterior fossa constricted area. We can do some studies, I'll show you in a minute, with CSF removal and with LP studies. We also can look at responses to agents like Diamox and Topamax that have recognized effects on reducing intracranial pressure, and also of increasing, with our knowledge of patients with connective tissue disease, what effect does cervical traction, cervical collar use, and cervical cervical thoracic orthotics that can somewhat extract the head and relieve some significant craniocervical instability. Well, here's some pressure tracings with a failed Chiari patient post-op Chiari. We were doing some studies years ago looking at removal of CSF and waiting a period of 10 minutes or so, and then infusing this back into the spinal canal. And when you take a little spinal fluid off, you can see that there's a pressure drop initially. By 10 minutes, if we return the CSF in a closed environment, we see the pressure gradually increase. And this is indicative of the fact that the patients have difficulty dispensing with that increased CSF load. They're not absorbing the stress of added CSF fluid. We know that the CSF is produced at a constant rate no matter what the pressure is. So this is where the problem lies in raised intracranial pressure, as a difficulty with absorption of CSF. We can see the patients have normal responses to hyperventilation. Hyperventilation reduces CO2 and leads to vasoconstriction, which can produce some sudden drops in CSF pressure, which we see in these downward spikes. And certainly when we take off CSF, we can see similar drops in intracranial pressure. These are just some other examples of similar maneuvers with patients with chronically raised intracranial pressure, with CSF removal and addition of CSF, which is very poorly tolerated with raised intracranial pressure that is only subsequently relieved by removing spinal fluid. So as with pseudotumor, some patients are treated initially with repeated CSF. Sometimes that works and the system somehow maybe adapts. But generally, if that is that and the use of agents like Topamax and Diamox are not effective, it becomes a neurosurgical, not a neurological problem. So what are the hints to the Chiari presentation of a headache? Well, it's a posterior fossa localization, which was early on observed, and a host of associated problems, which are not as striking in the Chiari population. Sleep disturbances. Oftentimes, the syndrome is exaggerated by trauma. Patients may go through life till they're 25 or 30, have a minor or less than minor craniocervical trauma, whiplash injury, and suddenly have an increase in headache that is frequently thought to be a secondary gain and malingering kind of problem, and oftentimes ignored by neurologists because they feel that it's the trauma that's caused this. Well, the trauma has caused it, but it's just exacerbated the underlying problem caused by the constriction in the posterior fossa. Looking for scoliosis, which occurs in 10 or 15% of Chiari patients, can also be a good hint. Orthopedic guys do this, but neurologists don't usually tend to be too attentive. And scoliosis can be hard to identify unless you really get the patient significantly unclosed so you can see the position of the spine and have them forward flex and move and identify the presence of scoliosis, or use scoliosis screening x-rays to identify some of that. Dizziness complaints that defy other explanations. These are very common because of the constriction in the posterior fossa area and the lateral parts of the brainstem where the vestibular nuclei lay. And there's a whole other discussion of the vestibular components to Chiari. In the EDS population, we look for tachycardia and postural orthostatic tachycardia syndrome. Oftentimes to be alert to the fact that patients have neck pain without significant cervical spondylosis. Now, frequently you do an x-ray and you don't think too much about it. Everybody after they're 25 begins to have a little cervical spondylosis. But, you have to be careful that you look for Chiari malformation sometimes in that, and you're not misidentifying or attributing some of the complaints to just cervical spondylitic chronic changes that nothing much is done about it. Irritable bowel symptoms and joint hypermobility in neurologists' hands have to be increasingly clearly looked for to identify this 30% group of patients that have connective tissue disorders. Now, we don't know as yet whether there's a genetic association here, but certainly connective tissue disorders may not necessarily produce a Chiari, but they produce a syndrome that mimics the Chiari symptomatology, and that's for certain a part of the process. So if moderately elevated CSF is an issue, if periodic LPs to reduce pressure may be helpful or of some sustained benefit, strategies like Diamox, Topamax, and Neptazane, which sometimes should be tried early on to relieve headache, aren't helpful, then in the presence of certainly of neurologic deficit, intractable headache, we're clearly more in need of more definitive treatment, which is a neurosurgical issue. And that's what the neurosurgeons will talk about, through the whole process today. Thanks very much for your attention. I'm looking forward to the group session for questions. Thank you.